Good morning. I'm Dr. K. Wang, a close friend of Dr. Smith. He kindly invited me to put the video session on his world-famous ECG blog. I'm thankful for that. This morning, I'm going to talk about ST segment elevation in conditions other than acute myocardial infarction. As you know, when a patient comes in with a chest pain, the first thing that you would like to know is the ECG, whether there's a ST elevation or not. There are many other causes of ST elevation besides myocardial infarction, so it will be very important to be able to tell them apart. In fact, the most common ST elevation is a normal ST elevation. I will come back to that later. This patient has a 10 millimeter ST elevation in V2. Is this a STEMI? Well, judging from the T wave in V4, which is a tall, tented, pointed, narrow, this is an example of hyperkalemia causing either pseudo-infarction pattern or acquired Brugada ECG pattern. What is Brugada syndrome? That's a congenitally defective sodium channel causing ST elevation in limited to V1 and 2 mostly, and they are prone to sudden death, especially when they are sleeping. Hyperkalemia also can disable the sodium channel. Then during that period, you can have acquired Brugada ECG pattern like this. How does it different from the patients with the STEMI and the right bundle branch block? I put two tracings side by side. One is just Brugada syndrome, and the other one STEMI with the right bundle branch block. You can tell the difference right away. Here, there's a distinct transition between the downstroke of the R prime and beginning of the ST elevation. Here, the elevated ST segment begins from the top of the R prime and continuously downsloping, ending in an inverted T. You certainly can tell difference between this and this one. If you showed me just the V1 and V2, without hesitation, I would have said this patient has Brugada syndrome. But if you show me the entire tracing, including V4, where T wave is tall, pointed, tented, and narrow, I would say again, this is another patient with a hyperkalemia, disabling the sodium channel, causing acquired Brugada syndrome. Now, this patient has about 3 millimeter ST elevation, but believe it or not, this is a normal ST elevation. Easily 90% of healthy young men and 20% of women throughout their age will have 1 millimeter, 2 millimeter, up to 3 millimeter ST elevation normally. Here's another study involving 6,000 healthy men in U.S. Air Force. 91% of them will have 1 to 3 millimeter ST elevation, mostly in V2. So I collected from 10 different healthy men who all have ST elevation, especially in V2. The deeper the S wave, the more the ST elevation. The ST segment is all concave. Wouldn't it be nice if normal ST elevation is all concave and infarction causing ST elevation is convex? Yes, normal ST elevation is all concave, but infarction is not always convex. This is a definite STEMI of anterior wall, but the ST segment is not convex but concave. So what's my attitude about the convexity or concavity? I wouldn't say it's useless. I still make a very good use of it, but in some cases it is not that useful. In some other cases, it doesn't matter because the findings for STEMI is so overwhelming, so that it doesn't matter whether it's a concave or convex. So I still make a good use of it. This patient too has ST elevation, especially in V3, but there's a notch at the junction. This is the typical early repolarization pattern that you are all familiar with. This is another kind of normal variant. There's a notch at the junction, ST elevation, but instead of a tall T, like in early repolarization pattern, this patient has inverted T. This is another kind of a normal variant. And unfortunately, not many people are familiar with this. So keep in mind, early repolarization pattern as a normal variant, and this is the other normal variant. There's no name given for it, so for the time being, I'm calling it the other normal variant. Another example, there's a notch at the junction, ST elevation, inverted T wave, and this is the other normal variant. This is another example of a normal variant, or the other normal variant. There's a notch at the junction and ST elevation ending in an inverted T wave rather than tall T wave like in early repolarization pattern. If you are not familiar with this pattern, certainly some of these patients will be thought to have either pericarditis or acute infarction, and in fact, some of them actually went to cath lab. This patient has a QS pattern in V1, 2, and 3. Combine that with the ST elevation. No wonder, so often this will be mistaken for acute MI. Why, however, this is only LVH doing it. Why should LVH cause a QS pattern in V1, 2, and 3? And it's explained with this vector cardiogram. This is a vector loop of the QRS projected on the horizontal plane. Patients anterior, posterior, right, and left. Normally, it's like that. Impulse begins here and progresses this way. With the LVH, not only the loop becomes bigger, but it swings posteriorly. So to V1 and V2 and V3, no electrical forces coming toward it, all going away from V1, 2, and 3. No wonder LVH will register QS pattern in V1, 2, and 3 normally. Combine that with the ST elevation, normal ST elevation, no wonder this can be so frequently mistaken for STEMI. So I have 4 patients with the LVH without and 4 patients with the LVH with acute STEMI. You can appreciate the difference. Here the ST segment is all concave and T wave is upright. Here the ST segment is convex, and better yet, T wave is inverted, which means it's concordant with the deep S wave here. So appreciate LVH alone, LVH combined with acute MI. Left bundle branch block is another cause of ST elevation, especially in V2. This patient has about 8 millimeter ST elevation, but no infarction. Wouldn't it be nice if ST segment can manifest concordantly with the QRS, like here, STEMI of inferior wall, STEMI of the high anterolateral wall, STEMI of the posterior wall registered upside down, but the anteroseptal infarction has no way of manifesting concordantly with the QRS because the QRS is mostly down, as the segment is up, no way to manifest as concordant changes. This patient has about 13 millimeter ST elevation with the left bundle branch block, but no infarction. So I collected 5 patients with LBBB without and LBBB with acute STEMI. Appreciate the fact that the ST segments are all concave, convex here. Better yet, T wave is inverted, which means it's concordant with the major component of the QRS. Here, T wave is all upright, discordant from the major component of the QRS. I hope you will appreciate the difference between LBBB without and LBBB with anteroseptal MI. This patient has a diffuse ST elevation involving all precordial leads, but not only that, it involves limb leads as well. So diffuse ST elevation. Combine that with a PR segment depression, which is an atrial injury pattern or atrial counterpart of ST elevation. This is a good example of acute pericarditis. Another example of acute pericarditis, diffuse ST elevation combining precordial leads as well as limb leads, and the PR segment depression, which is an atrial injury pattern or atrial counterpart of ST elevation. This patient has a diffuse ST elevation involving the precordial leads, but this is from a patient who had a massive PE and the right ventricle is severely dilated, which is also known to cause ST elevation. We were seeing this patient in the surgical ICU, and we didn't know what we were dealing with. Diffuse ST elevation, but turned out that severe metabolic or electrolyte problems can cause diffuse ST elevation like that. You can notice that the ST segment begins from the top of the R and it's continuously downsloping, ending in an inverted T wave. This is another patient after DC shock to the precordium in an attempt to convert atrial fib. You can have a transient ST elevation. So if this happens to your patient, don't feel bad thinking that you gave a massive MI. This actually happens in about 15 to 16% of the times. How do those ST elevation differ from STEMI, where ST segment is as tall as the height of the R wave? Here, you can have a squaring or shouldering or plateauing. It is not downsloping. Compare here. Brugada syndrome, the elevated ST segment begins from the top of the R prime, down, continuously downsloping, ending in an inverted T. ST segment begins from the top of the R prime, continuously downsloping. ST segment begins from the top of the R, continuously downsloping. Same thing here. So I hope you will appreciate the difference between STEMI, very much elevated STEMI with the ST segment as tall as the height of the R wave, but still different from these kind and these, from 9 different patients who had the STEMI. Sometimes stress cardiomyopathy, before they become typical stress cardiomyopathy pattern, they may have a transiently ST elevation. So that's another thing to keep in mind. This is not ST elevation at all. ST segment actually begins here. But this was misinterpreted as Q, then ST elevation, ST elevation. This is a broad S wave, broad R prime in a patient with Epstein's anomaly. So beware. Something may look like a ST elevation, but actually ST segment begins here, there, or there. This is a part of, from here to here is all QRS. So many conditions can cause ST elevation, especially in V1, 2, and 3. Sodium channel blocking agents like hyperkalemia, sodium channel blocking agents, or Brugada syndrome, or cocaine, or high fever. And this list is getting longer and longer. Right ventricular overload with a severe dilation during PE, or fatty infiltrates, or compression of the right ventricle from tumor, or normal, most common ST elevation actually, or normal variant, or LVH or LBBB. Of course, STEMI will do that too. Of patients with chest pain and ST elevation, 85% in one study and 51% in another study had a diagnosis other than MI. 85%. Can you believe it? Of consecutive patients who received thrombolytic therapy, 10% from the study done at this institution and the 6% study done in other place did not have MI. And what makes up those cases? The first one is LVH here, as well as LVH down here. You remember that LVH causing QS pattern in V1, 2, and 3, and ST elevation? No wonder. That's the most commonly mistaken entity. Of course, LBBB, or early repolarization pattern, or ventricular aneurysm, because they have a ST elevation. If you doesn't know that it's a chronic finding, it may look like acute infarction. So helpful clues are shape of the ST segment. Is it continuously downsloping, or is it plateauing, or squaring, or shouldering? Leads involved, other ECG findings, clinical setting, and old tracing if available, and awareness of conditions that mimic MI. So to review, this is a normal ST elevation in 6 precordial leads. This is an early repolarization pattern. You can recognize it by this notch here. This is the other normal variant, again notch there, but the difference between here and here is that the T wave is upright, T wave is inverted. This is also normal variant, more exclusively seen in black men and black women. So let's go over this quickly. LVH alone, even though it's a QS pattern and ST elevation. Left bundle branch block. This is the only case that had the ST elevation in the precordial leads as well as the limb leads. Combine that with the PR segment depression, good example of acute pericarditis. So I'm showing tracings of V1, 2, 3, and lead 2 from 7 different patients who all have ST elevation. This is a hyperkalemia causing acquired Brugada ECG pattern or pseudo-infarction pattern. Finally, this is STEMI. How about this one? This is anteroseptal STEMI combined with right bundle branch block, which is distinctly different from Brugada syndrome in that here, as I'm repeating, the elevated ST segment begins from the top of the R prime, continuously downsloping, ending in an inverted T, while here there's a distinct junction between the R prime and the downslope of the R prime and the beginning of the ST segment. You can tell the difference between this and this. Just as there are many breeds of dogs, there are many causes of ST elevation. Thank you for your attention.